get started?
Thanks, Debbie. So welcome everyone to our monthly virtual fireside chat. Thank you all for tuning in from with us in Indiana here and Eldoret, and obviously wherever else you're calling in from around the world. For those of you who don't know, I'm Adrian Gardner. I'm the executive director of the Ampath Consortium and director for the IU Center for Global Health, and I'm joining here from Indianapolis. In Eldoret, as many of you know, at the IU House, we've held fireside chats really since the 1990s to provide a space to learn and reflect with our trainees and visitors. And we're hopeful that as cases of COVID-19 in Kenya appear to be declining, that we'll soon have trainees gathered around firesides again in Kenya. But for now, we're in a virtual environment. We're grateful technology allows us to keep up these discussions monthly, to keep us connected and share our program updates and lessons learned. Just as a reminder that Debbie said, please keep yourselves on mute during the talk. You're welcome to ask questions using the Zoom chat or afterwards during the Q&A period. So today we're thrilled to have with us Dr. Samson Caprono, Dr. Toby Maurer, Dr. Esther Freeman, joining us to discuss the many strides being made in dermatology, care, training, and research. I'll just briefly introduce them and then we can get started here. So Dr. Caprono is the head of dermatology at Moi Teaching Referral Hospital and a lecturer at Moi University. Dr. Maurer is professor of clinical dermatology at IU School of Medicine. And Dr. Freeman is the director of global health dermatology at Massachusetts General Hospital. And I think Dr. Collier, who was going to join today, wasn't able to get a good connection. So she's one of the Fogarty Fellows, but I'm sure that Dr. Freeman, Dr. Maurer, Dr. Caprono will all talk about some of the work that Fogarty Fellows have done over the years and how important they've been to the program. So I want to welcome you all and thank you for joining to share your work and tell us about what's happening in dermatology. So Toby, I'll turn it over to you.
Thank you, Adrian, and thank you everyone for joining. Really just very grateful for all the support that we've had for many, many years through Ampath, through Indiana University, and the work that we've done with our collaborators. Just want to give you a bit of a whirlwind tour as an introduction and sort of go through the years that we have been working at Ampath, but a real quick tour. Let's see if we can get this going. Oh, not quite sure. Let's see. Not quite sure why this isn't advancing, but we'll try. Let me try this again. Escaping. No. Debbie, we got it. Oh, there we go. Okay, great. We're very proud to actually have clinics that are functional and highly functional, I'll say, at MTRH. And of course, Kip, Samson Caprono, as we call him Kip, can speak to that and talk to the eventual formation of these clinics that we've had. And what's going on with that as we speak. But at least we have sheets that say MTRH derm clinics now. We're extremely proud of that. But this all started about 12 years ago or 13 years ago when Jeff Martin, our wonderful epidemiology colleague at UCSF and working over in Uganda, really came over to me at San Francisco General and said, hey, we've got these thousands of Kaposi sarcoma patients in Uganda and Kenya. What are we going to do with these people? They are dying. We don't know what's going on. And we feel that if we can detect Kaposi sarcoma early, we will have a chance at increasing survival. And so it was that really we started working in Uganda. And through this early detection program that we had, I ended up being in Kenya, in Eldoret. The rest is history, and we can talk a little bit more about that as we go on. But that was really the introduction, bringing the research and the clinical to Kenya. And so it is that these are some of our colleagues, Helen and Miriam from Uganda, that have been there with us from the beginning. This is Sarah Coates, one of our fellows, and we'll talk a little bit more about Sarah and her work. But really, this is our team from Uganda bringing the work to Kenya that still continues to this day. And just to show you that, again, this is a nice collaboration, not only in Kenya with IU and Ampath, but involves our colleagues in Uganda at the Institute, in the Infectious Disease Institute, and where we do a lot of our translational work as well. And our lovely lab, again, work going between Kenya and Uganda at all times. And we take that work to various places to showcase what we do. And here's Esther, my wonderful colleague, who has done so much. And she'll speak a little bit more about the work and the mentorship. Again, we're with Helen and Devin, one of our students who's worked just tirelessly on the research end of things. We also, through all the work that we were doing, both clinical and research, realized that we needed to increase the quality of life of some of our patients who had terrible swelling of their legs from Kaposi sarcoma. We brought a team of medical assistants with us from Laguna Honda Hospital in San Francisco to teach our nurses and staff how to put on these Una boots. And not only did we put them on, we made them at our pharmacy. And kudos to Sonak and the whole pharmacy program who made these Una boots that we ended up putting on our patients. It really has changed a lot of people's lives in Uganda and Kenya. And this is Eileen and her lovely family over here, but we'll talk a little bit about the Fogarty Fellows that we've had. Eileen was Fogarty Fellow #1 in dermatology ever, and she did some tremendous work, and that work continues. Sarah Coates, of course, followed her, continuing that work. And then Sigrid, as we said. Unfortunately, Sigrid has, as Adrian said, a bad connection and can't join us this morning. But she has been our wonderful Fogarty Fellow through this last year, even though she has not had the opportunity to go to Kenya, but she's been there every step of the way. And then, of course, this is our wonderful Haji over in Chalimbo, doing the work of getting those Una boots on, washing the legs, washing the feet. And he continues with us in both the research and clinical capacity, and has been instrumental in putting together what we are now calling the Kaposi Sarcoma Center of Excellence, both in Eldoret and Chalimbo. We'll talk a little bit more about that. And here's Isabel on the call with us, and we are showing off our phototherapy unit here. We are very proud of that. Throughout this whole time, we've been in great contact with Wilson Liao, Tina Bhutani in San Francisco, who really put or let us have a phototherapy unit that we brought to Eldoret after several years, and we provide phototherapy for our patients in Eldoret. And again, just a nice picture of our phototherapy machine over here, and our staff, very proud to be in our rooms in Chandaria, where we have our derm clinics going on. And we have also, through the years, put together a dermatology curriculum, which I know Kip will speak of, but this has taken years and years to put together. We want to have a training program for our residents, those persons who have finished medical school who want to be trained in dermatology. We've got a 4-year program, and this is just our meeting. Kip, that was in 2018 to really put together the curriculum and to push that forward, again, with a lot of work. And we have introduced a teledermatology program, and again, very proud to have everybody's input on that. This is one of our computer rooms at Ampath in Eldoret, and this is Dave Felker coming from Indiana University, helping to put this all in, implement the whole thing, and we'll talk a bit about that. And then finally, this is actually at Indiana University at the Cancer Center. And I was walking through there to find pictures of our patients on the wall, really showcasing what we do in oncology and clinical care in Eldoret. And it really just shows to me what we call reciprocal innovation. And those ideas that we're bringing from Kenya, we're bringing them back to Indiana University and all of your universities, using those principles to advance care in the United States and elsewhere, not only in oncology, but in other fields, certainly in dermatology. And where we're going right now is with telemedicine, trying to use what we have in Kenya, bringing that back to the United States, and particularly Indiana and the state of Indiana, to enhance care for all our patients. So thank you to Ampath and Eldoret in particular, and MTRH and MOI for providing those principles of care. And with that, I'm going to stop. That's the whirlwind. Adrian, take it away.
Thanks so much, Debbie, for the whirlwind photo tour here.
Thank you.
So let me just open things up before we get started in sort of some of the care programs. Just want to give each of you on the panel sort of an opportunity to sort of tell a little bit of your background and how you got started in this. So let me start with Dr. Caprono. If you could tell us a bit about your background in dermatology and actually dermatopathology, and how you joined the Ampath effort, as well as your current role at MTRH and Moy University.
I'm Dr. Caprono, and I joined Ampath when it started with an HIV program. That was in 2005, 2007. And because of that, then I was taking care of patients in West Pokot and Kitale. But my interest in dermatology started from then, when I saw so many patients with dermatological services, dermatological conditions, which required treatment, and we didn't have a good treatment service by then. That's when I joined the residency program, and after my dermatology residency program, I did my fellowship in dermatopathology, and I finished my fellowship in 2014. That's when I joined also Moy University. So when I joined Moy University, then I met Toby, and we had one interest in common, and that was developing dermatology services in Eldoret and western part of Kenya. And our actual interest was how to expand the dermatology care. And this one brought us now to the issue of the dermatology curriculum and the training. And apart from the training, what we also wanted was to improve the care of patients with dermatological conditions, and also improve the research in dermatology. So that's when I really joined, I joined Ampath, and that was my entry point to Ampath. And then while working with Toby, and that time I was employed in Moy University. So while working with Toby in developing the Ampath dermatology program, I also, that's the time also Eileen came. And when Eileen came, that one boosted a lot the development of the program. And at the same time, I met Esther, which was a great inspiration also when it came to research. Then Sarah came in, and I think with all that, then we joined as a team. I think from my side, that's how I came into Ampath and my dermatology background. So I practice mostly as a dermatologist and also as a dermatopathologist. Thank you so much. I think I'll stop there.
Thank you. Can I just ask Dr. Caprono, can you also just comment on the, how many dermatologists are at MTRH or in Western Kenya? And how...
So I think as we speak, probably when we use the word dermatologist in Kenya, it might have some different meanings, but basically speaking, is if we don't talking about residents in dermatology, someone who's done residence in dermatology, then currently we are about 7. But there are some short courses which are being done, and these short courses are being done in UK for 1 year, and there are a number of people who've done it, and they practice as dermatologists. So in western part of Kenya, basically, we have 2 dermatologists at the moment.
Great.
So what supplements the dermatology services in western part of Kenya is actually the dermatology clinical officers, those clinical officers who've done a 2-year program. And I think as we will be talking about our teledermatology, then we'll discuss the role of these dermatology clinical officers in providing dermatology care, especially when it comes to our care center of excellence.
Great, thanks so much. Dr. Freeman, you want to say a quick word about how you got connected here?
Yeah, absolutely. So delighted to be here today, and Dr. Caprono, so an honor to go right after you. And I think some of the important points that you brought up about really our lack of dermatologists and the training programs in sub-Saharan Africa are pretty limited for dermatology. This training program in Moshi, but I think one thing that we've talked about is the importance of really creating more training opportunities for folks interested in dermatology in sub-Saharan African setting. And I think Dr. Caprono is talking about is so important. So I'm a MD, PhD trained dermatologist and epidemiologist. And so my background is in infectious disease epidemiology. And I worked across sub-Saharan Africa during my PhD looking at the role of different roles of Eastern and Western sub-Saharan African HIV epidemics. Then came back to Harvard and did my MD there, followed by my dermatology residency at Harvard, and then decided to marry these 2 interests in a career in global health dermatology. I was really lucky to start working with Toby and Jeff and Dr. Caprono in Kenya, now probably somewhere in the 6 to 10 years ago timeframe, to really help build Ampath dermatology. And my particular area of interest, is certainly as a researcher. And I think the area that I work in is HIV-associated cancers, and how do we improve care and access to care for our folks with HIV-associated cancers and HIV-related skin disease in general. I collaborate with Toby at the World Health Organization, working on guidelines in 2014 for HIV-associated skin conditions. So that's the area that I work in. And another thing that's really important to me is mentorship. And it's actually really fun for me right now because several of my mentees, some of whom just started with me, are on the line as well today. So this is actually their first introduction to Ampath dermatology as well. So, Toby is one of my mentors. So I feel like there's like this overall mentor tree, family tree that happens. As you mentioned, Sigurd, one of my faculty mentees, who is a Fogarty Fellow, I think there's just some wonderful opportunities through the NIH and other ways to train kind of our next generation of global health dermatologists, wherever they may live.
Great, thanks, Esther. I see there's a lot of young Kenyans on too. I can see future dermatologists all over the place. But Toby, let me also invite you to make you've already sort of walked through the photos, but give us a little bit more about your history or what are the unique aspects of the Ampath partnership that have facilitated your work.
Thanks, Adrian. And I see a lot of people on this line to whom we owe our appreciation for all the work and support. So I ended up, as I say, in Kenya just by chance, really. I was asked to come and teach some people how to do biopsies for KS, for that early detection in KS, really working through the IDEA grant that Kara, of course, is on the line and has pushed that IDEA grant for now, 16 years, Kara, I think. So anyway, that's how I got to Kenya and was doing these biopsies, and by chance met Joe Mamlin, who basically said, yeah, research, okay, that's great. I'm glad you're doing that. But what are you doing for our patients, damn it? What kind of care can you get going here for our patients? And so that really did start my interest in bringing clinical care to our patients. With that, as I said, we certainly did put together, are trying to put together a curriculum so that we can teach the next generation of Kenyans some good dermatology, not just a 1 or 2 year quick course, but the full Monty, so that they have the equivalent training of dermatologists throughout the world. And really, we're looking at a 4-year course that also includes research techniques and some epidemiology, really growing from the work that Esther and colleagues have done. So that really is where we're going. And then as part of that, we still have kept that research going, and have been really thrilled to keep pushing that research, primarily in Kaposi sarcoma, but other HIV-related diseases, research in phototherapy, research in wound care and Una boots, and we can talk a little bit more about that. And we would like to keep having our Fogarty Fellows come on over in every capacity, but certainly in dermatology. Ampath has been a very rich place to learn, to do research, and to build clinical services. And as I briefly mentioned before, we have now what we're calling our Kaposi Sarcoma Center of Excellence, which provides clinical workup for our patients, appropriate treatment for our patients, and offers studies and clinical trials to our patients so that they are getting world-class Kaposi sarcoma clinical care and ability to join research.
Great, thanks, Toby. So let's get into the thick of things here. So Dr. Caporno, if I could start with you. As you know, Ampath's motto of leading with care. So we're going to start with a little bit of the care program, and then we'll touch on the education and research. But can you tell us sort of briefly, summarize what are the barriers that exist to patients with Kaposi sarcoma and other dermatologic conditions in Kenya, and why is a center focused on KS important to Kenya?
Hello, Adrian. I can't hear you.
Oh, you couldn't hear me?
Yeah, I can hear you now.
Okay. I was just saying, I wonder if you could start by sharing with us some of the barriers that exist for patients with Kaposi sarcoma in particular, but other patients with other dermatologic conditions as well. And why is a center focused on KS important?
I'm not getting you.
Can you all hear me?
I can hear you now, but I didn't hear your question.
Okay. I was wondering, can you share with us some of the barriers to care for dermatology?
Okay. So I will break it in 3 ways. And the first one is access to quality health care. And when it comes to access to quality health care is quality dermatological care. So the first thing that we have is we need a functional skin clinics. And what I mean by functional skin clinics is being manned by at least a dermatological officer who can adequately treat common dermatological conditions and then refer cases which require some further treatment. Then the second one is the other barrier to quality care is having good diagnostic services, which is lacking at the moment in our setup. So the diagnostic services that I mean in this case is being able to make an appropriate diagnosis, whether it is through clinical diagnosis or supportive diagnostic investigations. And one of the things that we use in dermatology is biopsy most of the time. And being able to do the biopsies is really important. And in our setup, the biggest challenge is being a peripheral facilities being able to perform skin biopsies, and then processing those biopsies, the time it takes to process the biopsies, and then getting the results and getting quality results. That's another major challenge in our setup. So that's one of the major barriers in our setup. Then the third one is now the treatment modalities which are available. So the treatment modalities which are available, we can look at it in 2 parts. One is availability of the treatment modalities. So most of the time, we have a limited range of the treatment modalities. An example is phototherapy. So if you look at phototherapy as one of the treatment modalities, in Kenya at the moment, we only have 2 centers. So in western part of Kenya, it's only available in Eldoret. And if you have to look at it like if you have a patient from Kisumu, from Tulaimbo, from Busia, then it's very difficult to have those patients to be done for the therapy 3 times a week. So treatment modalities, the range of the treatment modalities is low. The second thing is the cost of those treatment is also expensive and many patients cannot afford. Then the other thing that we look at it is the medical insurance coverage. So we don't have adequate, not so many Kenyans are covered by medical insurance. And even if they are covered by the medical insurance, the NHIF, then this NHIF, the cover does not cover for everything. And therefore, some of the investigations, some of the treatments the patient has to pay. And knowing also that skin conditions, Kaposi sarcoma and the others, they are chronic diseases and they are quite expensive. And in the long run, most of the patients will not afford, and therefore compliance becomes low. Then there's also the cultural beliefs, especially when it comes to cancer, which is common in all cancers, is there are some barriers to access to care, especially with Kaposi sarcoma, when patients, they are told that it's suspected to be a cancer, and they don't want to be biopsied because they believe if you do any surgical maneuver on a cancer, then it will spread and the final results is not good. So there are also some cultural beliefs that really impairs, like taking biopsies, and these patients needs a lot of counseling. So I will break up my barriers in that way. Okay,
Excellent.
thank you.
Thank you. Yeah. So Toby, tell us a little bit about teledermatology and how that's overcome some of the barriers, at least that Dr. Caprono outlined. Oh, you're on mute.
All right. We started using teledermatology, actually implementing a whole server system and teledermatology a couple of years ago. Has been somewhat slowed down because of the pandemic. We really just were getting started when the pandemic hit. And so we really have had some delays, but I think the pandemic has also underscored the need for teledermatology, not only in Kenya, but throughout the world. The idea is, of course, for peripheral clinics, primary care providers to capture photographs and send them to the specialist, that would be KIP, who will read those photographs. Derm is a no-brainer because we have access to the skin and good photographs. So he will read that, he will send results back to the primary care providers. We are starting this, of course, really trying to find our patients in the early detection mode, our patients who have Kaposi sarcoma. So we're really concentrating on that. But that is the idea in general, not only for Kaposi sarcoma, but we will expand that obviously to all other dermatologic diseases. We also hope to implement that right into our training program, which Kip could talk a little bit more about. But this will be the basis for not only clinical care throughout Western Kenya, but we hope that the new generation of learners in dermatology will be schooled on how to do teledermatology, how to do the reads, how to communicate with their primary care providers throughout Western Kenya.
Great. And maybe Toby or Dr. Caprono, maybe just why do we need a center of excellence for Kaposi sarcoma? Maybe just to sort of make sure we're all on the same page here with regards to why do we have so much KS in Kenya?
Maybe we can let Esther talk about that, since she has done all the epidemiology backup on that, and she can tell you exactly what is going on with the incidence and prevalence of KS and how we hope to change some of what we found. Esther.
Sure. I think just one comment on kind of global burden of disease. I think that when we think in the United States, for those of us that might be here that think about Kaposi sarcoma as an HIV-associated malignancy, we think of something that has, for the most part, improved, or not completely gone away, but significantly improved with the advent of antiretroviral therapy. And what we've seen in sub-Saharan Africa and in Kenya specifically is that certainly while some of the incidence of Kaposi sarcoma has decreased and the number of new cases, we're still really seeing a substantial burden. And to put this in perspective of why this is such a big deal is that if you looked at the incidence of Kaposi sarcoma in Kenya and Uganda, for example, they're actually higher than the incidence of prostate cancer, which is the most common solid organ malignancy in the United States. So I just want to give people the sense of when you walk around in a ward, in Eldoret, you're seeing a lot of Kaposi sarcoma patients, and you're seeing patients with very severe and advanced disease. So about 70 to 80 to 90% of our patients are coming in with what we would consider advanced stage KS, advanced stage Kaposi sarcoma, which means that in addition to antiretroviral therapy, they actually require chemotherapy as well. And we also know that the survival right now for our patients with Kaposi sarcoma is very poor. And we're looking at about 40%, we lose about at least 40% of our patients in the first 2 years. So survival is very poor, incidence is very high. And so this together is kind of a perfect storm of a major clinical problem, which is, I think, where the birth of the Kaposi Sarcoma Center of Excellence came out of, because you might say, why KS? Why not something else? And it's really because of the clinical need that we were seeing, which is very different than, for example, the clinical need that you might see, in North America or in Europe. So I think it's really important to kind of follow the local epidemiologic trends that we see.
Great, thanks. So I think, the Ampath dermatology program is really a great example of how this sort of iterative conversation between research and care. So maybe Esther, let's stick with you for a second. Just can you tell us about some of the research initiatives that are ongoing, the U54 idea that Toby mentioned already, and how they've helped to inform the care program?
Yeah, absolutely. So we've been really lucky to have funding through the NIH for a number of different programs. We've just come off of a 5-year grant and just started a new 5-year grant, U54, which is a large collaborative effort at really making sure we're also beefing up the research skills of our African collaborators as well. So these projects are really run by African principal investigators, which is really key. And I would say that Toby and I play a little bit more of kind of a backup role to our African principal investigators who are kind of running, more running the show. Some of the areas of work we're looking at is how do we get patients with Kaposi sarcoma into care faster? How do we create linkage between HIV and oncology services? Some of the papers that we're working on right now are related to that Dr. Caprono mentioned is around stigma and HIV and cancer and skin disease. Dr. Caprono also touched around this concept around fatalism and cancer and how much that can affect people's perceptions of cancer in this setting, how much this can affect people's ability to relate to care. And another piece that we're working on is, for example, cost effectiveness research on different chemotherapy regimens for KS. And then I think the last piece that Toby touched on as well is we're working a little bit on point of care diagnostics. And so how do we create, think of the traditional dermatopathology, you do a skin biopsy, and someone like that, we're so incredibly lucky to have Dr. Caprono, who's trained to read skin biopsies, but it's challenging. We need really a lot of resources to make the traditional dermatopathology route work. And so things like point of care diagnostics, or the idea that you have a lab in a shoebox and you can take a small piece of someone's skin and you can put it into this solar powered PCR machine that's half the size of a shoebox. And with that, you are able to be able to give someone a diagnosis of cancer literally while they're standing right in front of you before they go home. So those are just a few kind of teasers of the variety of work we're doing. And I think the key is really making sure that it's really done with our colleagues that are, in Kenya and in Uganda, to make sure that it's really filling the gaps and the needs that they see.
Awesome.
And I'll add 2 more areas that we're really working on very hard. One is, of course, the whole NHIF, trying to make sure that we can support the chemotherapy that these patients will need. And so we are trying through Indiana University, actually, and kudos to the dean there, who has agreed to support the premiums that are needed for chemotherapy, at least as a pilot program, so that we can see exactly what is needed, how it works, and that we can hopefully start to see just what we can do to bring appropriate chemotherapy to the patients so that we increase their survival. As Esther pointed out, 40% of our patients are dying, and these are patients who are between the ages of 30 and 35. So we're taking out a huge generation of patients. So this is really looking at NHIF, and I know people on this call are working so hard on figuring out what we do to support healthcare in Kenya, and we also are right on in there trying to do that. The other area that we're working on and that we hope to touch on with regard to diagnostics and improving diagnostics is, of course, artificial intelligence. And those pictures that we hope to obtain, pictures that we have already obtained. We're working with the National Library of Medicine in Washington, D.C. to try to train our computers to recognize Kaposi sarcoma through photographs. And again, this is our effort on early detection of Kaposi sarcoma and other dermatologic diseases so that we can get a head start on what the diagnosis is, work with our dermatopathologists to confirm disease, and then apply appropriate therapies. So these are huge efforts. It takes time and diligence and motivation, but we've got it, and we've got the support. So again, many thanks.
Very exciting. Thank you. Dr. Caprona, let me come back to you. So I noticed that Dr. Chang just joined, so I wanted to make sure that you had a chance to actually, because you had mentioned earlier that her presence as a fellow really helped to move things forward. So can you, maybe each of you can talk about the role the Fogarty Fellows have played and the bigger picture here and move things forward.
Dr. Caprona, Esther, or Dr. Caprona, do you want to talk a little bit about the role of the Fogarty Fellows you had mentioned earlier?
So, as Dr. Toby had said initially, Eileen was our first Fogarty Fellow, and she played a major role in developing some of our systems. One of them was actually pushing in development of HIV dermatology care, and so the other one was participating in development of our curriculum for the MNet program. So the Fogarty Fellows actually play a major role in supporting the systems that are currently in place and also developing other systems. I think I will give Esther and Toby to also discuss on that.
Sure, thank you. Esther,
I can give kind of just a brief primer about what it is for those who haven't heard. Fogarty is one of the centers of NIH that focuses on international work, and the Fogarty Fellowship is an organization where you are sponsored by the NIH to spend 1 year at a site that's already a partnership site, and Ampath is one example of that. And as Toby mentioned, we have had 3 fellows in the past, 2 who have been able to spend a full year or almost a full year at Ampath, and then my current Fogarty fellow, Sigrid, who has been grounded due to COVID, so who's been working, in absentia on a lot of these issues. And I don't know if, I think I did see Eileen pop up, but I don't know if she's able to turn on her video or join us for some comments. She's one of our Fogarty fellows. It's possible she's not in a place that makes that possible. So Toby, I can turn that over to you.
Okay. Yeah, so Eileen, if you can only listen in, you were our first Fogarty Fellow on the ground, and wow, have you done a lot of work and continue to do a lot of work. But some of the projects that you worked on, of course, as Kip said, working on the curriculum, and Kip can talk about some of those challenges of getting the curriculum authorizations moving forward. Eileen was also instrumental in putting together what we call our KICS study, which was on lymphedema and Kaposi sarcoma, and has worked beautifully with Haji in Chilimbo to push that forward. And that has been the basis of ongoing work that we're doing throughout Eldoret. Eileen has also worked on some of our tissue work, that we brought tissue from Kenya over to Kampala, where we were looking at basically various pathways, cytokine pathways in Kaposi sarcoma. Another huge effort, logistic difficulties, but that was really a very nice illustration of how translational science can be done, also collaboratively between our two centers. And then, of course, Sarah Coates came onto the scene, and her fellowship on the ground was cut short by the pandemic. Oh, I see Eileen saying she can't talk, but she's listening, and thrilled to see dermatology represented. Thanks, Eileen. But and Sarah is also, as I say, one of our fellows who really pushed not only the phototherapy that was started with Isabel and Eileen, but also pushed our pediatric clinics and introduced dermatology clinical care into the pediatric realm. And so did some research with that, and really also started some research on drug eruptions, which we were doing in collaboration with our South African dermatologists. So we hope to get that reinvigorated, restarted. And Sigrid, Esther, do you want to just say a few words about what Sigrid's work has been this last year?
Sure. She's been working in areas around stigma, in Kaposi sarcoma, and has also been working in the area of something we call intervention mapping or implementation mapping, which is really trying to map key gaps in our care cascade. The concept of a care cascade is that between someone being diagnosed with a disease and then going all the way through to treatment and remission is a multi-step process, kind of like a waterfall cascade, and that people fall off of this cascade at every step of the process. And so she's been looking at different steps in the care cascade between diagnosis of Kaposi sarcoma all the way through treatment, and seeing where our patients are kind of falling off and how we can address some of these gaps to really retain them in care and to improve the quality of their care.
Wonderful. Thanks, guys. I might just interject that the applications through the various Fogarty consortia that we're a part of are actually open now. So through November 1st, I think. And Debbie's inserted the link in the chat for those that are interested in fellowship. So, all right, let's move. Well, let me just say, Esther, I know you have to go to another commitment. So thanks for your time. Very much for being here. Let's move a little bit to some of the educational program. So when we talk about the future of Ampath dermatology, or really any Ampath program, of course, the future is in education. So Dr. Caprono, can you tell us what are the plans for postgraduate training program in dermatology at Moore University?
So we started planning for a dermatology program, a residency program in 2014. I think that was our first meeting, and we didn't know exactly how the curriculum looks like. We sat with Toby in our room and thought about how to develop dermatology program. By 2018, we had a draft curriculum, and we wanted a stakeholders meeting. So we had a stakeholders meeting, and we looked at the needs assessment. We looked at where we need to develop according to the requirements of the university and everything that was needed. And after our stakeholders meeting, then we had our first draft. And this first draft, we've been pushing it through the university. And currently what we have, it has been approved at the quality assurance, and just waiting for one more step. And then we can have a fully approved curriculum. And our hope is that by September next year, we can have our first residents. Now, we're looking at a bigger picture. So if we have a residence program, then we can train dermatologists who can serve in most parts of Kenya, because there's a huge need. And our aim is to provide a quality education system, a quality training program that can actually meet both the clinical care and also research. So we intend to have our first team of trainees by September next year, hoping that COVID will go down, because our aim is to have a collaborative teaching, and we intend to have teachers or who will come and teach also in more university. And because of COVID, actually it slowed down the process a little bit. But with we're hoping that by September, if everything goes well, then we can have our first group, then take them through the training, and then have them with the collaboration with the trainers from other countries. And this will really improve the training and the quality of care. Now, the other thing that we really intend is to have these residents also provide supportive care to the region, and this involves having teledermatology that the clinical officers and also any other can upload the pictures into the system, and we have our residents look at the pictures, discuss with them as part of the training, and at the same time providing care for those satellite areas within the Western region, and also in the whole part of Kenya. So if we have a system which our residents will be looking at the pictures, and then we make recommendation for treatment. And also, this also will provide access to referral system, like such cases, some cases which really needs to be referred to a dermatologist. Then we will avoid unnecessary referrals because of the distance. So the teledermatology will come in and in diagnosis of the patients, and also providing supportive care to the region. So that is how we intend to develop. Also, the other thing that teledermatology comes in is when it comes to discussion also with the regional centers. So that if we have a center of dermatology in Jaramogi Oginga, that is in Kisumu, then or in Tulaimbo, then if we have a clinical officer who is there, and we continue discussing the cases with them, then they will be learning also on their side. At the same time, our residents are learning. So it's a two-way process.
Wonderful.
So that is from my side.
That's great. Thank you. Toby, do you want to expand a little bit on some of the goals and maybe some of the challenges actually that you face with the educational program?
Yeah, it's never easy to put together a post-grad program. Lots of committees that have to approve it. I was shocked by that. I guess it makes sense in some respect, but boy, it's been a long time. And Kip has been present the whole time, reviewing, renewing, everything that we've had to do to get this curriculum pushed through. But we are hoping that we will really be a center for training, certainly in Western Kenya, but perhaps as a role model for other countries as well. We're actually trying to take the same curriculum to Uganda, so that we can perhaps even share the knowledge and the teachers. Our hope is that we will, with Kip, teach full time and supervise full time, and perhaps even bring our professors from our consortium universities to Ampath, and hopefully even to Uganda, where you can imagine a professor might come from dermatology, let's say at Duke. And if anyone's sitting there at Duke listening to this, we're hoping that this becomes a reality. So they would come for a 2-week period and teach along with Kip in Kenya and with our colleagues in Uganda as well. And so that is the plan, is to really make this a partnership in teaching. We are hoping, and this has been my dream also, is that we take those principles that we learned of teledermatology, bring them to a place like Duke, for example. And what we will do there is have our Duke dermatology program and residents provide teledermatology for their patients, for their vulnerable populations in the area. Perhaps raise some funds, which will then allow them as faculty and residents then to go back to Kenya and provide teaching and care in Kenya. So we really want to make this a reciprocal program, not only in Kenya with a few consortium universities, but our whole consortium of universities. Again, same principles apply everywhere, and we're hoping to bring those ideas back and forth.
Thanks, Toby. I think it's worth even underscoring that even further. So I think this whole concept of reciprocal innovation, this idea that we've developed models, we're working with our Kenyan colleagues in Kenya, but some of those same models can be applied, and the principles can be applied, to serving underserved populations here in the U.S. and Canada and other parts of the world. So can you tell us a little bit more about where have you started having those conversations? Are they moving forward, or?
Yeah, well, definitely. We are working, have always been working with Duke, with Brown, with Mount Sinai. We actually have a young trainee, dermatology trainee at Mount Sinai, who is interested in pushing these ideas forward in the New York area, but also coming to Ampath and perhaps even applying for that Fogarty Fellowship. So we're hoping to do this work throughout, even with our Canadian group in Toronto, hopefully in Edmonton with our group there. So we've been making the rounds trying to push these ideas. But also with regard to expansion, we're looking at our expanded Ampath programs, our programs that we hope to have going up in Ghana, our program that we hope in Mexico. So we've been working with USC and UT Austin to do exactly this with teledermatology and to really push the programs that we hope to expand. And maybe you can talk a little bit more about that, Adrian. But we're also looking forward to some work in Nepal. So I'll take it back to you, Adrian, to speak to those programs that you're trying to push.
Thanks, Toby. So yeah, maybe just a quick word because we're running out of time here. But so yeah, as Toby mentioned, Ampath is in the process of replicating the model of institutional partnership in Mexico and in Ghana and hopefully Nepal as well. And we're really working through the Ampath consortium model to interface with the institutions in those host countries to replicate this model of institutional partnership. And some of the models of care delivery may also get replicated, but certainly the principles of the partnership that have yielded so much sort of a strong collaboration in Kenya over the years. So I'm going to encourage people, if they have questions or comments, please put them in the chat, or we'll give you a chance to come off mute in a second. But Dr. Caprano, just as a sort of a closing thought, I wonder if you could, to many in the audience who may be future Kenyan dermatologists, what would you encourage them to do, or what would you say as words of wisdom?
I think dermatology is a great field, and I think there's a lot of need of dermatology training in Kenya. There's still a huge need for dermatologists in Kenya, and currently we don't have a training program in Kenya to be a dermatologist, but hopefully by next year we will be having a dermatology program and really invite those who want to be dermatologists that they apply, and we hope we'll have you'll have a good training program that we are putting up together. Thank you so much. I think also in the field of research, I think there's still a huge need for research in dermatology in Africa. I think it's quite underserved, and most of the things that you read, there's a huge difference between the black and the white skin. And we really need a lot of research in this field if we have to have a good quality care for these patients. And then also, we need more of the teaching in the black skin so that we can have good patient care in this field. Thank you so much. So I think it's an interesting field and welcomable.
Thank you so much, Dr. Parna. Very important last thought, actually, in terms of just the equity and all of our teaching and things. We absolutely need more examples of what these conditions look like in people with darker skin. So again, just want to sort of say thank you so much to Dr. Pacono, Dr. Maurer, Dr. Freeman for sharing your incredible work and impact you're having on the people in Kenya. And thank you so much to everyone really for tuning in. This work relies on the support of people like you and the donations that allow Ampath's work to serve patients and their families. We're grateful to our Kenyan collaborators and also the support of our partners. If you're interested in supporting the initiatives we talked about today, please feel free to reach out to us. And just to put in a plug for next month, we are honored to share a conversation with Dr. Roger Glass, the director of the Fogarty International Center and associate director for international research at the NIH, as our October Fireside Chat. This opportunity is going to be held in coordination with the 2021 Reciprocal Innovation Stakeholder Meeting, which is hosted by the Indiana CTSI and the IU Center for Global Health. So this is really a special opportunity for Ampath supporters to hear from Dr. Glass, who's really been a strong advocate for our partnership in Kenya for many, many years. So please join us Wednesday, October 13th from 8 to 10 a.m., 3 to 5 p.m. Kenya time. And I think Debbie has put the link in the chat for the registration for that. Toby, let me give you any final thoughts, or if not, I'll just thank everyone for joining us and for all your partnership with Ampath.
Final thoughts, just a big thank you to everyone, and we hope to continue the work that has already been done over these last 12, 13 years and see the fruits of all this labor. Thanks, everyone.
Thanks for sharing your email address there for anyone.